Kia ora koutou, no mai haere mai to tonight's webinar on Healthier Clinicians equals Healthier Patients. My name is Katie McCulloch, I'm a nurse practitioner. Tonight's topic will bring you a practical discussion that covers the essential steps, support and benefits of moving from burnout to balance, work-related mental injury, and co-creating a psychologically safe workplace. Our speaker tonight is Dr. Leanne Rowe. Leanne is a clinical professor, a rural GP, and co-author of Every Doctor, Healthier Doctors equals Healthier Patients. Her Doctor of Medicine thesis is on the topic of GP mental health training, and she was a past chairman of the Royal Australian College of General Practitioners and Deputy Chancellor of Monash University.
Welcome, everyone. Before I bring my slides up, I'm going to just go straight into the presentation and cover a common scenario that you will all have faced. So let's just fast forward to your commute home tomorrow. So during the day, you've made hundreds of clinical and other decisions. You've had a heavy patient load because you've had to cover a sick colleague. Many patients presented with complex disease and mental health issues requiring long consultations. And you did a great job in supporting everyone, including the other practice staff. And as you commute home, there are a few thoughts stuck in the back of your mind. Perhaps there were a few patient complaints about waiting times. Perhaps you had terse words with another colleague whose behaviour was strangely out of line. And when you get home, you plan to flop in front of the TV news with a glass of wine, trying to block out the stress of the day in a futile attempt to hide it from your family. And it sometimes feels as if no matter how hard you try to do things perfectly, it's never good enough. And you do this again the next day and the next. And this is really a blueprint for burnout. And there are many background issues that are predisposing you to burnout. Here are some of them on the screen. So here are some of the intractable health systems issues that you'll be facing in New Zealand the way we are in Australia. So firstly, an unsustainable health system. We have financially non-viable general practices. We're still dealing with waves of COVID-19 and other disasters. And actually today, I'm streaming this from central Victoria, where we've had a hugely dangerous fire risk, very hot day with a northerly wind, followed by a huge thunderstorm. And I'm sure there are going to be claps of thunder and strikes of lightning, which will come onto the screen as well. We are also dealing, in Australia, we're dealing with a mental health crisis. We've got shortages of mental health professionals, and this is directly related to the fallout of the prolonged lockdowns during the pandemic. We're facing workforce shortages. These are acute on chronic workforce shortages, and consequently we work unsafe hours and have heavy patient loads. We have the dark cloud of medico-legal risk, and increasingly we're confronting patient anger and sometimes violence every day. So these are some of the really hard challenges that each of us face in general practice. And today I'm speaking to the whole team in general practice, but I am going to focus on GP mental health because there are some specific barriers for GPs in seeking help and getting comprehensive mental health treatment. And so I would like to emphasise throughout my talk those special issues for GPs, because they do directly impact on practice staff. And I know there are practice managers and practice nurses here today, and pharmacists and some other health professionals. So please know that I'm thinking of this audience as being a very broad audience, but I'm definitely focusing on GP health because it impacts everybody in the practice. So who am I and why am I qualified to speak on this topic? So I've been a GP for decades. I've also had some leadership roles, which have given me some additional experience. I graduated 44 years ago, which, I've collected some hard experiences along the way, and I've learned a lot through those things. sometimes I feel that there have been missing things in the medical curriculum, in the training programs, that just haven't equipped me for the challenges that I've faced. And I feel that now, late in my career, that it's time to really share that experience and really just create a conversation and a discussion in the profession about what we can do to protect ourselves and prevent a lot of the mental health problems that we're seeing. And so my talk is entitled Healthier General Practice, Healthier Patients, because really behind what I'm saying is that I'm actually advocating for high quality patient care. And to do that, to maintain that every single day, we need to be healthy and we need to be proactive in protecting our health. So I've just included a few photos about me. I live with my husband on our 20-acre farm. We produce organic olive oil, and we have beautiful black Labrador. I have two grown-up, impossibly well-adjusted sons who tolerated all sorts of challenges through our time in rural practice. And those of you who've done the Milford track will recognise the middle picture. One of the things that I attribute to the healthy upbringing that we gave our children is that every January, from about when my sons were 10 and 11, we would do a great walk or two in New Zealand. And these, of course, are hugely challenging, require a lot of preparation and teamwork. And I'm sure that those of you who have climbed the first day to the top of the peak on the Milford track will recognise this scene, that often you arrive in the rain and the weather. And this is enormously, well, I think it's a great experience for children in how to deal with adversity and how to get through it. So I thought that you might enjoy that reflection. And then Katie kindly mentioned our book, Every Doctor. And this book, the second edition, is really special to us because we wrote it as we're emerging from the pandemic with all the lessons. And we found that the book really changed from the first edition. And we've included many doctors' stories and experiences, and there is definitely a focus for early career doctors. But what we encourage people to do is we really encourage every doctor to read the book, because we believe that there are some very important messages for senior doctors in caring for their younger colleagues. And tonight I'm going to focus on solutions. So I've just outlined some of the really deep challenges that we're all facing, and we know all of that. We know that the job is hard. So I'm going to shift now to a solution-focused presentation. Like you, I've attended many webinars and conferences on doctors' health, and often I find that their presentations on Resilience 101, I'm speaking to one of the most resilient audiences who I could speak to. You've had a busy day in practice, and then you've made time to attend this webinar. You've dealt with huge challenges in the last few years, particularly, and and continue to do so. And if I was to put this presentation to music, I would probably sing it to the tune of "I Did It My Way," but instead I would insert the words "I did it the hard way." And as I said, I just don't think that it needs to be that hard. I think that we can share solutions, and so that's what I'll focus on. And those of you who have done the Greenstone walk will recognise this beautiful scenery. So here are the main topics for today's presentation. From burnout to balance, and I'll talk about advanced psychological protection, just as we protect ourselves now physically with special tailored physical protection. We also need to think about tailored advanced psychological protection versus generic self-help, which clearly all of the things related to exercise, nutrition, mindfulness, and aromatherapy and whatever you choose to do for relaxation are important. And I know that you recommend these things to your patients every day. But I'm talking to an audience who needs to have a good talk about advanced techniques for protecting ourselves psychologically. And then secondly, I'm not sure if you can hear that thunder in the background, but it's quite soothing actually. The second topic is intractable work-related mental injury. Those of you who have been in practice for a while will know that for decades we have seen statistics, unacceptable statistics related to mental health problems in doctors and in other clinicians. And these issues are intractable, and these problems are work-related. They are work-induced. And because clinicians rarely make work cover claims or work-related claims to be compensated for mental injury, well, GPs don't. You know, there is underreporting of this in workplaces, and but I think that we need a different approach, and I think that there are solutions. And then thirdly, psychologically safe workplaces. We'll talk about workplace culture, contemporary human resources management, and also becoming comfortable with conflict, because we're having to deal with conflict every day in our practices, and sometimes we're not good at that. So let's start off with from burnout to balance. And as I said, I'm promoting advanced, tailored physical and mental protection. And here are a few of the principles that I'd like to go through in more detail in some other slides. And then after this section on burnout to balance, I'd really like to open up to some questions from you, because we do have some time, and I'd like to get a sense of where you're at and the sorts of things that you would like to discuss. So firstly, my first point is that overwhelm is a justified response to excessive stress. So like going back to your commute tomorrow after work, you know, if you had excessive stress, then feeling overwhelmed and out of control and you know, a high degree of uncertainty is an absolutely normal response. And sometimes acceptance of that helps a great deal. The other point that I would like to make initially is that we often are overstimulated during the day, which means that this interferes with our sleep. And there is a lot of information out there about generic sleep hygiene. And I often see doctors as patients. And in my experience, and actually my own personal experience, generic sleep hygiene doesn't work. And well, anyway, because if you read the advice, the first thing that is often stated is that sleep is really important for your functioning the next day. And sleep is really important for a whole lot of health reasons. So I would put to you that in the middle of the night, when you have chronic insomnia and you wake, the first thing you might think about is that the first thought that will come to the mind is, I can't sleep and I won't function the next day. And not sleeping is bad for my health. Well, those thoughts are very counterproductive. You won't sleep if you have those thoughts. And so even the basis behind generic sleep hygiene is actually a little faulty, and that's why acute on chronic insomnia is common. And unfortunately, we know GPs commonly self-medicate for this, which is in temporary situations, you know, to use melatonin or something very mild is, you know, may be okay, but never self-prescribed. But I would put to you that there are non-drug insomnia interventions that are really effective and in the long term and much better for you. And the specialized sleep intervention that I recommend is by Dr. Giselle Withers, who has a wonderful website, A Mindful Way, and she has an intensive insomnia intervention that really helps. It's over a 6-week course, actually. And you will immediately say, well, I don't have time to do that. But in fact, if you can't sleep, then you do have time, because you can get up, laying in bed, ruminating is not helping you, and you can get up and do the sleep course. So, there are please have a look at it anyway. Please have a look at her site, because she really does advanced techniques. She uses mindfulness, but she really explains why generic sleep hygiene doesn't work and what you can actually do about that. The other important point, of course, is to schedule leave without guilt. So sick leave actually amongst doctors is more common since the pandemic, because of course we know we shouldn't turn up to work with a flu-like illness, because it could be COVID and we could be giving that to immunocompromised patients. So, now we do protect ourselves and we tend to take sick leave, which actually has workforce implications. But taking annual leave, long service leave, and parental leave are also really important. And this is part of your right to a safe workplace. And so please schedule in leave proactively. But the other 2 points I'm going to discuss in more detail, firstly, meticulous time prioritization, and I'll go through a slide in a moment on that, but just to introduce that topic. So often we talk about time management and time control and having more control. Well, I would argue actually that in general practice, our lives are fairly chaotic, and it is hard to have that sense of control. And so what I like to advocate for is time prioritization, because we do have that under our influence. And the other point I will enlarge on is eliminating unhelpful rumination when we're off work. So, we have a challenging day at work, and then we ruminate a lot about what we could have done or we should have done or what we have to do tomorrow. And we don't give ourselves a good break when we're off work, and we don't use our time off effectively. And so let's start talking about those topics. So meticulous time prioritization. There are 168 hours in a week, and I would encourage you to do a really brief diary. I mean, just off the top of your head, how you spend your 168 hours. What do you actually spend your time on? So you've got sleeping, you've got work hours, you've got household duties, you've got family time. Just look at the proportions of what you spend your time on. And then when you look at your list, identify to you what matters the most. What are the things that you should really prioritize above all else? And that will be a personal choice for you. But the other thing that you will notice when you do this list is that actually you have quite a lot of flexible free time, but you're wasting it. You're wasting your flexible free time off work. And so we'll go into that a little more detail. You'll also say to me, well, I work 80 hours a week, so I hardly have any flexible time off. Sometimes the workload some weeks are just totally unmanageable and really undo you. But I would say to you, well, in those weeks, it's really important, super important to have meticulous time prioritization, because you need to really use whatever little time you have off work in a really constructive way. So some obvious things: delegate appropriately. Please get help to do your house tasks, your gardening. Please don't renovate your house when you have small toddlers. I say that from personal experience. Please don't do that. Please have a really good accountant and other professionals. Please delegate what you can delegate appropriately, because you can't do it all. And then everybody says for you to set boundaries, but isn't saying no difficult? Because, you know, like you, I've been in many situations where I've tried to set boundaries, and when I say no, I get such a guilt trip or I get such a pushback that I think, well, I may as well have done that thing. So I think it's just so important to carve out time for solitude, and say no to things that are not, are not what matters most. Okay. So, today I carved out time to speak to you because I believe this is a really important task. And so, that's my choice, that I spend a couple of hours preparing and then speaking with you. And so we make those choices in our everyday lives. But what I'd also say is, when you free up your flexible time by delegating appropriately, etc., do less. Don't fill that extra time with doing. We're high achievers and we need to be productive. Actually, being is actually quite a challenge, but really worthwhile. So, reducing addictions, including socially acceptable addictions, so addictions to our smartphones and alcohol, food, TV, shopping. These things are superficial distractions that are harmful to us and take us away from things that really matter most. So have a think about those socially acceptable addictions that actually are doing you harm. And then we'll go on to eliminating unhelpful rumination, because I bet when you did your list, you identified that actually you are ruminating a lot about your work. But and of course, debriefing and thinking about how you're going to deal with challenges is of course important. But when we're overthinking and going over and over and over and can't get a thought out of our minds, then this is harmful to us. And I'd put to you that, the scenario right at the beginning of the presentation was that you did a really good job during the day. You saw, so many patients and spent a lot of time on complex issues and helped a huge number of patients, but also the practice staff. And yet the only thing you can think of on the way home was that some people unfairly complained because you kept them waiting, or that, you had a little bit of a conflict with one of your colleagues, which of course is going to happen because, there are hundreds of challenges, and these systemic challenges that I raised early in the presentation set you up for tension and for conflict with your colleagues. And so we need to be more accepting that tension between colleagues happens and actually can be quite constructive. I'll go into that a little bit more later. So how do we reduce unhelpful rumination? This is harder to do. It's easy to say, harder to do. So this is a little technique that I've learned, and I've based on the book by the late Dr. Claire Weeks, who was a Sydney GP, who in the 60s and 70s wrote a book on helping your nerves, which was basically about how to manage anxiety. And it sold millions of copies worldwide. And she was nominated for a Nobel Prize. She's really unrecognized. And I love these stories about great doctors who contributed so much through their writing. And she was a shining star who helped so many people with just a really common sense approach. And I think with self-help books, sometimes, there's a whole lot of new shiny books with marketing titles, but actually sometimes the really solid advice from experienced colleagues is really important. So what I do is I usually tailor this, and I'd encourage you, this is what I do, but you might tailor your approach and adjust it accordingly. But so what do I do on one of those days where I've had a really heavy day and I'm ruminating, and I know I shouldn't, but I just can't help it. So what I do is this. So just find a few minutes peace. Which again, I know it's hard to do sometimes, but a little bit of peace. I just take a blank piece of paper and I write down every challenge, every concern and worry that is on my mind, at the front of my mind and the back of my mind. And when I often find the sheet is covered with realistic worries, like things that have gone wrong, might go wrong, things that I need to do tomorrow, people who I need to respond to, just minor things and major things. I put it all down on paper. Then when I look at that, I think, well, no wonder I'm feeling this way. And often the thing that I'm ruminating is not actually the major problem at all. So often that process actually helps me identify what's really behind why I'm ruminating. Then I look through the list and I cross out what I can't change. I just have to accept what I can't change. But I do identify what I think I can influence. And then I diarise, because I can't do it all on my time off, but I diarise what action I might need to take for those things that I can influence. And that gives me a greater sense of probably just influence and maybe a little bit more control over what I can do. And if I focus my mind on what I can influence, I stop ruminating on things that I can't. And then I have a time where I float above the problems, and I try to look down on the problems as if I'm above them, like I'm external to them. And that is a process of mindfulness, which just helps me let go and just helps me relax the body and gives the brain a break. Understanding personality traits is really important, because I mentioned again in the scenario, the commute home, understanding your personality traits. So many of us are perfectionists. We try so hard to get it perfect every day. Well, it's an impossible goal. And, look, my GP is a perfectionist. I like that. I'm glad that he follows up my pathology results and, cares and seems to have the perfect persona. Yes, I expect that too. But really, we need to understand those personality traits, because what makes us good doctors and good clinicians and practice staff is not what makes us good in our relationships and our parenting at home. And so we need to have a think about that and how we adjust those traits. And then to connect with people who love you is just so important. So don't sit, you need time for solitude, but don't think that you can shut out the people who love you and pretend that they're not impacted by the stress of your work, because you bring it home. And I think young people are mind readers, and they know when you're stressed. So my final slide before we break for some questions, Katie, is that on nurturing home as a sanctuary. And there's just a few points that I'd like to make here on doctors' children, because I had 10 years of my career working with homeless youth in Geelong, in Victoria, in Australia. And this was a really challenging but enjoyable time for me. I just learned so much about adolescent health and adolescent mental health. And with some great co-authors, I wrote a number of books on parenting and adolescent depression. But the thing that I'd like to share with you today is that at the homeless youth clinic in Geelong, I also saw doctors' children. And I identified that actually there are special challenges in doctors' families, and this relates to the stress at work that, of course, you find difficult to share. We as GPs, we find that difficult to share with our families, firstly because it's confidential. Secondly, because sometimes the things that we see in our work are very traumatic. And, it's not appropriate to share that with our children particularly, or even our partner. And so this means that we have special parenting challenges. The other thing is that we tend to, if our children run into problems, we tend to know a colleague who we think we can self-refer them to. This completely undermines the ability of our children to seek medical and psychological help independently. And from an early age, a lot of young people need confidential professional assistance, and can't do that if their parent is hovering in the background and is a friend of their clinician. So I just ask you to think about some of those challenges. This book was published a long time ago. You might find it in the library now, but it reflects on a lot of what young people taught us. And I learned a lot about, a lot of people say there's no training for the most important job in the world, parenting, but there is actually. There's training and there's research, and the effective parenting style is authoritative rather than authoritarian, which is the you will do as I say because I said so kind of parenting, or the permissive style of parenting, which is, you can do anything you like because I'm just too stressed to care. And often parents sort of swing between the two extremes, which is even worse for young people. When one method doesn't work, they'll swing to another, to the extreme, from authoritarian to permissive, and that inconsistency is actually even worse. But the authoritative parenting style is warm, nurturing, autonomy granting, and firm with firm limits, and appropriate for a child's development. If I could reflect on, often I'm sure like you, some patients really impact on you and you remember them for your whole life. And I remember one girl who came to see me. She was about 15, and she talked to me about some challenges she was having at school. And she actually came from a very loving, supportive family, and she was able to identify that her parents were great parents. And the reason they were so great was that they would listen with their kind eyes. And sometimes on the way home from school, her mum would stop the car and just give her full attention while she was talking on the way home. And in that small act was a way of just communicating unconditional love to that child, which gave her strength then to deal with some really awful challenges at school. So those sorts of experiences in general practice are really amazing insights into life and into parenting, and I'm sure it influenced my own parenting to do that work. The other thing that I would challenge you to do before we open for some questions is to ask your children what they think you do at work. And these little quotes come from some very young children and what they have said to others about what their mummy does at work, their mummy who is a doctor. So you can read them. So my mummy cuts off sick boobies and puts new ones back. That's a 5-year-old daughter of a breast surgeon. And my mum is changing the world. That was a quote from a 7-year-old to explain to his teacher why his mum had not turned up for the parenting day at school. And mummy helps babies breathe. When she doesn't come home, a baby has died. That was from a 5-year-old child who had absorbed from her neonatologist mother that, why she didn't come home at night, that, it meant that she was working long hours and that usually a baby had died, which clearly she had internalized and shared with someone else, but had not shared with her mother. So I just raise those little examples for you as some of the important reflections, I think, from my work as a GP with young people. So, Katie, could we open for a few questions just to break things up?
We sure can. So please put through some questions for Leanne through this section. I personally, I feel like I had a little bit of I feel silly saying it, but a bit of an aha moment when you were talking about the reducing the unhelpful rumination. Just putting down, I mean, I feel like that's a common tip to get down all your thoughts, but then to sort of cross out, you know, the things that you can't change and then look at what's actually affecting you, I think would be really, really helpful. Because as you say, it is often the thing that you're not potentially focusing on. It's the small thing that's irritated you to get to that point of overwhelm or overstimulation. Yeah.
Absolutely. So some simple techniques. And I think it, you know, I advocate for tailoring it to you. So I advocate, if that doesn't work for you, well then, you know, you'll find the things that work for you, but have a strategy, you know, because we all have those days. We all have those days of being overwhelmed. And so have a strategy for that. And the next section, I'm going to deal with mental injury because, you know, the question then is, what happens if those simple techniques don't help? What happens if the sleep intervention, the specialist sleep intervention doesn't work? What helps if you can't stop ruminating despite trying those things? And so we're going to go into talking about trauma and mental injury.
I love the idea of you know, looking at where you use your hours and how you spend them. But I feel like when you're already in that situation of feeling overwhelmed or stressed and you've got so many tasks, even just a simple task of sitting down and looking at where your hours will go, because I guess procrastination in itself is a stress response, right? And how do we tackle that?
I don't think there are any easy answers, but what I would say to you is that carve out some solitude. You can identify time. It might not be today or tomorrow, or it might be in a fortnight, but carve out time where you can sit in solitude and reflect proactively on how you're going to deal with it, how you're going to delegate, how you can manage the rumination, what you can use your flexible time on. There are things that you're doing at the moment that are not helping you. And so when you've got a period of solitude, it comes clearer to you. And I think the acceptance that the overwhelm sometimes is just a normal response just helps to settle you down a little bit.
The role of professional supervision, how do you feel that fits in as both the supervisor and the one being supervised?
Yeah, so I think professional supervision is just critical. You know, but a supervisor can't always be a mentor. You know, so a supervisor is often there for supervising training, you know, getting through exams and, you know, the sort of academic parts of the career. A mentor and a coach are different tasks. And I think that sometimes it helps to recruit those people as well, but they're hard to find. I think also that informal mentoring, I make myself available for informal mentoring and group mentoring because, you know, if you assign a supervisor or a mentor, sometimes people don't necessarily get on and, you know, don't particularly see eye to eye. So I don't think you can force it. But I think supervision, mentoring and coaching, we're not, in general practice, we seem not to have time to do that. But I think it's worth a try. You know, I think it's been shown to be very helpful. So good point. So why don't we keep going then, Katie? Because I think I can see the time ticking away, and we've got quite a lot to cover. So okay, so next one. So let's talk about intractable work related mental injury. So in Australia, I'm often hearing we have an epidemic of burnout in amongst medical practitioners, all medical practitioners. Okay, so that's, you know, it's a chronic problem. It's been going for decades, and then it's acute on chronic as we're emerging from the pandemic and the impact of the lockdowns, etc., in Australia. And I gather that you are also experiencing this in New Zealand as well. But what I would say to you, what I would challenge you to think about is this. So is it an epidemic of burnout, or is it actually mental injury or mental illness? And so if you were seeing a patient, I just ask you to think about this. So if a patient comes in and says they're burnt out, so how do you determine whether it's burnout, or if it's something more serious? So you might reflect on the ICD-11 criteria. You can easily search that. You might have some guidelines for mental illness, and you can think off the top of your head what the criteria for the diagnoses of these things are and the differences between them. But I'd just put to you, when it is actually you who is experiencing the burnout or the mental injury, then your self-diagnosis is flawed. And particularly so because assessment in highly functioning people is actually really difficult. It's challenging because, and we know this, a lot of GPs continue to work despite having mental illness, including trauma, because they put themselves last and they continue to function really well, but at great personal cost. And they just keep going. And if you do a superficial assessment, if you do a self-assessment, or if you go to another GP who administers a questionnaire, it will not be valid. It will often not be valid. And so how do you work out if it's burnout or mental injury? And the other challenges are these. So mental health stigma in medicine particularly predisposes doctors to late presentation, which sets them up for poor prognosis in mental health, and then relapse. And also, doctors often ask their friends or their colleagues if they could have a quick script for an antidepressant, or, a quick chat. And this is totally inadequate. And so often there are so many reasons why GPs particularly are predisposed to having mental health problems, not only because of the excessive stress and all of the challenges that we've just talked about, because then they have barriers in seeking help. And there are tailored psychological therapies that are really effective, but often GPs don't take the time out to seek that sort of help, often due to embarrassment or just because of their workload and the mental health stigma. And I just note this, that actually I did my Doctor of Medicine on cognitive behavioural therapy, and I really advocate for that as being a very effective psychological therapy. But sometimes even the CBT principles don't work for clinicians. And this is, so for example, if you know CBT, you'll have heard of faulty thinking, like catastrophic thinking, black and white judgments, and making mountains out of molehills. But actually, in general practice, sometimes things are catastrophic. Sometimes you need to make black and white judgments, and sometimes, sometimes there are mountains to climb and they're not molehills. So I think that it's very hard for someone who hasn't worked in general practice or in medicine to really understand the full nature of the challenges involved. And for that reason, we need to tailor our psychological therapies. But we do have evidence-based guidelines, and the guidelines I'd like to bring to your attention on trauma are from the Phoenix Australia guidelines. You can do a search for that, and you can find the early specialised psychological therapies that are so important in treating cumulative, repetitive exposure to trauma, which is, I believe, unrecognised. So, if going back to the first section on burnout to balance, if those strategies are not working for you, then that's actually a red flag that it may not be a simple burnout. It may be that you are experiencing mental injury, which is actually related to your work, but not recognised. And this is a really serious, common problem. I'm just going to speak personally here briefly, and I'm going to do that by reading a story that I wrote on discovering my own response to cumulative trauma. And I read this, I don't usually share my own experiences, but I wrote this actually just very recently and published it in the Medical Journal of Australia online journal, and it got a great response. And so I'd just like to share this story, and if you don't mind, I'll just read the story so that I get it right. But I think that many of you will identify with it. And the reason I'm sharing it, though, is that the awareness of this trauma was a great release to me, and just being aware of it has just in many ways changed my approach. And my only regret is that I discovered this so late in my career, and so I'd therefore like to share it with you. So here we go. So like many doctors of my generation, I recognise the personal impact of repeated cumulative trauma exposure later in my career. As a rural GP, I was the first responder to cardiac arrests and motor vehicle accidents in my community for nearly 30 years. And after any traumatic death, I never took time to grieve or debrief because I had to get straight back to work. I was needed. After I left the practice, though, I briefly returned to the local cemetery to visit the new grave of a friend. And during my search for her headstone, I stumbled across the plots of many of my other deceased patients, those who had died in car accidents, by suicide, in farm accidents, after failed CPR, or from terminal cancer who I cared for at home. It was as if I opened the locked gates to an abandoned cemetery in my head. The vicarious trauma associated with listening to stories of child abuse, intimate partner violence, and other horrific experiences, as well as the direct trauma related to being bullied and assaulted at work, seemed to be buried in the same subconscious graveyard. The first step to recovery from mental injury is early recognition. But these experiences are so common in healthcare that many doctors and other emergency personnel, including nurses and ambulance officers, often dismiss them as just part of the job. Acute horrific incidents faced by police at a murder scene, a state emergency service worker in a natural disaster, a journalist in a war zone, we recognise these as significant traumatic events. But what non-psychiatrists commonly underestimate is the damaging psychological impact of repetitive retriggering of work-related traumatic events in psychologically unsafe workplaces, particularly when there's no time for time out due to a shortage of healthcare workers. And in this environment, all healthcare workers seem to be suffering from chronic burnout and become expert at blocking emotions on and off work. But this unhealthy avoidance can be a psychiatric symptom. Confronting unpleasant symptoms of traumatic mental injury, such as suppressed anger, profound sorrow, unwarranted guilt, mental exhaustion, and overwhelm takes courage, particularly when a significant proportion of the medical profession continues to equate the disclosure of a mental health problem with career suicide. It's a very unfortunate term. It's time to make peace with ourselves and each other by fully validating and accepting our human experience in medicine. In the wonderful highs and inevitable lows of our medical careers, we gain unique insights into people and life. We share strong bonds with colleagues who have been there and recovered from workplace mental injury too. And we can experience joy and enormous amount of satisfaction and meaning and purpose in our work and our legacies. I've learned the hard way that if we try to patch up the trauma of life's jagged lacerations with tokenistic band-aids, our open emotional wounds continue to rebleed with future knocks. And my overwhelmingly positive message is this, that as a united profession, we can do so much more to co-create psychologically safe workplaces and heal work-related mental injury for future generations of doctors, for the health of and well-being of our patients, our families, and also ourselves. So I think that from that you can see that it touches me deeply, but my overwhelmingly positive message to you is that it helps so much to have that self-awareness and to seek professional help to talk that through. And so we're going to talk about the importance of having your own practitioner. And again, those of you who have walked the Milford track will recognise this scene and the enormous challenge it is to climb that mountain. But sometimes there's a beautiful view at the top. So let's just quickly go through PTSD and complex PTSD symptoms. So just very quickly, re-experiencing the trauma, avoidance of traumatic reminders, and a persistent sense of current threat, startle and hypervigilance are common, but so is exhaustion and inertia, and actually, if you like, mental collapse, and that sort of procrastination that you might feel, and inability to treat, to soothe yourself. And so for that we need to seek assistance. So PTSD symptoms are present for at least 1 month following a traumatic event. Acute stress disorder is really common, and that occurs between 2 days and a month, but also requires professional assistance. And again, I'm not encouraging self-diagnosis here, but just to raise a few issues. I'm being deliberately brief because we need professional assistance if we are experiencing any of these things. But there are evidence-based guidelines for trauma, and again, you can find these on the Phoenix Australia website. And there are a range of really effective psychological therapies, and also sometimes pharmaceutical treatment is required. So I'm advocating for an independent, trusted GP. Many GPs don't have their own GP. Practice staff often seek advice from a practice GP, which is inadequate. And so we need someone outside the practice. And now that we have better developed telehealth systems, this is now possible for rural and remote GPs. Why do I advocate for this? Because firstly, how can we do comprehensive preventive healthcare? I mean, how do you do your screening for diabetes, cardiovascular disease, cancer, and mental health screening if you just have corridor conversations with a practice GP? It doesn't work. And the other thing is that if you have a trusted independent GP, you get justified time off to get treatment. Okay, if you're in the same practice, they know, the person looking after you knows that it'll be difficult if you take time off for your treatment. And so you're not getting an independent opinion. You often need time off for treatment. And I've mentioned before that doctors tend to present with a late diagnosis. They're often in crisis. They're meeting their GP for the first time, which is not ideal. And then they're treatment resistant and they're prone to relapse because they don't follow up with consults properly because of the time demands in their practice. They don't receive comprehensive evidence-based psychological and pharmacological treatment according to guidelines. They patch themselves up. And it's important to note that crisis management is much easier where there's a trusted relationship. And this also prevents inappropriate notifications to regulatory bodies. And I know this must be an issue in New Zealand as it is in Australia. So there's a lot of fear, from unwarranted fear, actually, from doctors about being reported to regulatory bodies if they admit that they're depressed to their treating doctor. This is completely wrong, because if you know your GP and you go there with a mental health problem, your GP will know if your patients are at risk or not. And your GP will give you time off. And if you take time off, work appropriately, your patients are not at risk. And therefore, you do not require an inappropriate notification to a regulatory body. And this is clearly outlined in the guidelines by our medical boards. So please don't put off seeking treatment because of these unwarranted fears. Now, clearly, there are barriers to this. GPs need mental health training and long consultations, and I fully realise that this is not easy. So I realise there are a lot of challenges in this, but if we want our intractable mental health statistics to change, we need to change something. We can't do the same ineffective. We can't have the same ineffective strategies. So just in a lighthearted, I want to just have a lighthearted moment with you. So can I tell you that self-help doesn't work? And I know this from experience. I think I've read most self-help books so that you don't have to. Here are some of my favorite titles. How to mistakenly assume you have everything under control. How to live a long life by abstaining from anything that brings you joy. How to keep yourself so busy that there's no time to face up to your problems. How to treat others like they treat you so that everybody is miserable. How to discover new and better ways to live, but still stick to your old ways because it's easier. And the last self-help book you will ever need, that's the title, and the subtitle, Repress Your Anger, Think Negatively, Be a Good Blamer, and Throttle Your Inner Child. So just a little message there about generic self-help, and that, we are often given these generic strategies. And then when they don't work, we think, well, that was no point. That didn't work. Or we think, well, what's wrong with me? Because, I'm not responding to the self-help advice. Well, there's lots of reasons why you don't respond to the self-help advice, and here they all are. So I'm going to go on to the part 3, but Katie, have we got any questions before we go into part 3?
More statements, I think, that
yeah,
they like a lot of clinicians are actually contractors, so it's actually not that easy to take time off, which is really hard. They don't have sick leave. It's very hard to say no at work.
Yes.
Lots of those things that just impact on that ability to self-care.
So there's systems issues, and we need to change the system. And I think that, GPs are also reluctant to be employees. GPs actually like being contractors because it gives you a sense of freedom. You can work across multiple practices. There's quite a lot of advantages, tax advantages, and all sorts of things. But I think as a profession, we really need to look at these systems issues, because is being a contractor really a realistic way of working. And it is if you earn enough that you can actually self-fund your leave,
Yeah.
And but the thing is, practice owners also face this issue, because practice owners are earning less and less because of all the regulations and all the new expectations and all the new HR requirements and so on, and the admin costs and the wage costs. And so practice owners faced exactly the same problems as contractors. And so this is where we need our general practice associations and our colleges to really work on these things to help us with these systems issues so that we can take leave. I mean, I remember when my boys were young and we were going on the Great Walks in New Zealand, do you think our patients were happy with that? We got all sorts of comments about, you're going on another holiday. We haven't had one for a while. So I think that there is pushback from people, but I think it's about about examining what is really important in your life and what you care about most and where your priorities lie. And if that means taking, unfunded parental leave or unfunded sick leave, then I think we need to account for that and budget for that, in how we manage our finances. And saying no actually is a really major issue. And I mentioned this, that I've found it hard to say no all through my career, because as I mentioned, often there's pushback, and by the time I've explained why I have to say no, I might as well have done the thing. Okay. And then I feel guilty that I haven't done it. So, that plagues me. So I get it. I totally get the realities of this. Could I just reflect on one thing? I think this is also a practice culture issue, and we'll go into this in a minute. One of the really challenging things for me in everyday practice is this. I get to work. People don't say good morning. They're too busy doing their things. So it's not a welcoming environment. I do a busy session. People have no idea what the patients are talking to me about, and they're often complex and they're sad, and, it's, again, an exposure to trauma. And at lunchtime, if I do get a coffee, go into the morning tea room, and there'll be other practice staff there. And I have to say this, often, because I'm identified as the carer, the people in the morning tea or lunch room will load their problems onto me. And I find it really hard to put the boundary there and say, actually, just had a terrible morning. I can't listen to you now. And so what I'll do is then I'll sit in my room at my computer and have lunch on my own in my computer to, avoid that. The other thing that occasionally happens is you might, have cancellations of patients. And I think, oh, thank goodness I've got a cancellation there. And the next minute, a practice staff member has put themselves into that cancelled appointment and wants to see me for a consultation. Now, these are boundary issues, right? And another one will be, and actually I'll tell another one before I finish. Another one is this. So I need to pick, there's some days where I really need to pick the kids up from school. This is, a decade or so ago. So I really need to pick the kids up. If I'm not there, they're standing on the street corner, right? So I try to finish, on time. So I'll stop the patients, earlier than probably I need to, because I know what happens is that when I'm going out the door, someone will say, oh, could you just see this quick consult before I get out? Because before you leave, because, no one else can see them, and they're just a quick one. And, you'll be, well, how many times have I done that? And they're not quick. Like I remember one time at the Young People's Health Service, that situation happened, and it's just so quick. He's just got a sore throat. He's just got a sore throat, and it'll be super quick and you'll be able to go. No, it was actually an anaphylactic reaction. He had a sore throat because his throat was swollen. The next thing, I'm giving him oxygen and adrenaline, and my children are waiting on the street corner. So these are kind of every day. I know that all the, there'll be a level of frustration in this audience to say, well, she doesn't really know, she doesn't really know what it's like every day. Well, I do actually. All right. And what I'd say to you with those sorts of challenges, so you do that in and day out, and you don't put boundaries, you burn out, and you're no good to anyone because you leave the practice. And so you make a choice then. So then you step back and say, well, our practice has to understand and respect the boundaries that we really need to uphold to protect each other. And so these are the realities. These are the realities that I'd like to discuss at the practice meeting. These are the things that are happening to me, and I think they're happening to you too. And unless we step back and put those boundaries in place so that I'm allowed to go home, approximately when it's time for me to leave. I realise that's a vexed problem, but there's sometimes you just have to leave the practice and someone else should be able to cover for you. You know, it's not a solo practice. Someone else should be able to do that cover and respect that you have family responsibilities too. And I actually think that this issue is bigger than this, because in fact, I think for people who are primary caregivers at home, who are usually women, it means that women, whether they be GPs or other practice staff, they're working their minimal hours, not their optimal hours, because they know that if they work their minimal hours, they can get the family balance right. But if they work their optimal hours, then their colleagues will not understand when they have to take a sick day because their child is desperately ill, or that that they're unwell themselves, and they will, you know, they won't get that understanding, and so they tend to work minimal hours. This is a major issue for our workforce shortage, and I think if there was more respect for primary caregivers of children at home, then we would actually see people participating in the workforce more. So these actually are huge systems issues, which is why I've got this final topic of psychologically safe workplaces, because it goes to the key of how the system is setting us up for mental health problems. And unless we push back and actually together with like-minded colleagues find the solutions, we are trapped in this cycle.
You know, it's a culture, and it's a system change that we need to support those healthier clinicians.
That's right. And if there was one positive message, I mean, I'm trying to get through quite a lot of topics tonight, because my aim is just to challenge conversation. You know, it's not really to give a didactic talk or just, you know, come up with every solution, because of course I can't. I'm a GP, I try to fix everything, but of course I can't. So I'd just like to challenge conversation. But one of the things that would come out of this is, you know, if there's one thing you could do coming out of tonight, is when you have your next practice meeting, put this topic on your agenda, you know, about saying no and boundaries and healthy boundaries, because if people don't do that, they leave and they retire early and they find something else to do. People working in general practice, not, you know, the whole practice team are very smart people. They are smart people. They can work elsewhere, but they have their heart and soul in their work, and we need them, you know. And my talks are about retaining our workforce and not letting them go. Too many clinicians are leaving the workforce because of all of these challenges, and we have to say, what can we do? What are the hard conversations that we need to have to make you, you know, to make you think about staying? It's really critical for patient care. So third part, psychologically safe workplaces. So we, in general practice, we do not prioritise contemporary human resource practices and policies. I also work now in the corporate world, and I see this world of HR law and responsibilities of directors and employers, and it's huge. But your responsibility to provide a safe workplace is fundamental, absolutely basic and fundamental. And yet in general practice, you know, we're seeing, you know, poor management of patient complaints, unsafe hours, bias, discrimination, racism, bullying, sexual harassment, and even patient violence. And all of these issues are underreported because somehow we have this duty of care that we need to be selfless, but we must not be selfless when it comes to having a safe workplace. And I've written extensively, if you search my name, Leanne Rowe, for the MJA, the Medical Journal of Australia Insight Plus, you will see a lot of my topics I cover a lot of these hard topics, and I won't have time to go through them now, but they're also covered in the book, in Every Doctor. And it's fundamental that we have contemporary HR management for all the reasons we've talked about in the last 5 minutes or so. The other part of this is I've just recently written a book, an article on the positive duty to eliminate uncivil behaviours and bullying and sex discrimination and harassment in our workplaces. And in Australia, we have a new amendment to the Sex Discrimination Act, which puts the onus on employers to eliminate these things. And there are huge liabilities and fines involved, and the whole profession needs to wake up and come into the 21st century on these topics. I just mentioned before about the optimal versus minimal hours, and this relates to taking leave, time out, lunch break, finishing on time, etc., etc. I get it that some weeks you can't do that. I do get it. But if it's week in, week out, constant, you are not going to survive. It is humanly impossible to do that week in, week out. And we need to have practice meetings so people agree on what the rules are, that they don't ask you unreasonable requests, that they don't load all their personal problems on you in your lunch break, and all of the other things that add to the chaos of the day. I absolutely understand debriefing and being empathetic and being caring, but it's just simply humanly impossible to do that constantly. And so let's talk about positive workplace culture, because to actually have these hard conversations, we need to have a kinder culture and greater empathy for each other, and to care for our colleagues more. And one of the things I'd like to raise is around peer review and feedback and conflict. So there are tens of thousands more diagnoses and treatments. Like, we've got a fire hose of advances of medicine coming our way. And this means that there's a lot of grey areas in medicine. And I do a lot of medico-legal work where I see the worst things going wrong. And when I look at it, often a GP will be just in the wrong place at the wrong time, maybe exhausted. And it's very easy for me to look at the medical record and see what went wrong. But I know as a GP that when you're there in the moment and you don't have the full information, or it's the end of the day and you're tired, how hard it is to get everything right. And so I have a very empathetic approach to my medico-legal cases. And so what I think we need to do is to, we have this competitive culture sometimes in medicine where there's this one-upmanship and these unhealthy egos. Look, really, we need to promote peer review and feedback. We need to accept that actually there's a healthy tension in disagreement over patient care, because that healthy debate helps us get the right answer for patients. And getting regular feedback, often we're solitary in our consulting rooms and we're not sharing enough. We're not sharing our experiences enough, and, not in your lunch break. But because of that, of course, when you see a patient and then your colleague sees the same patient, there might be a there might be a differing opinion, because the patient, you have more information on the second consult. The patient's condition has progressed. So of course there's a difference of opinion. So please let us give each other a break and understand that peer review is a really constructive thing. It will keep you away from medico-legal action. It will save you from having a patient complaint. And with conflict, we're not good at dealing with conflict, would be my generalization, because we tend to stick to our guns and dig our heels in, and we're not necessarily objectively assessing the pros and cons of an action or a solution. We're sort of personally invested in our opinion. And I think we need to become much better at and actually expect that we will have conflict, and expect that that some days our colleagues won't be feeling well, and they won't be pulling their weight, and they may have behaviours that are uncharacteristic. And in those sorts of situations, we need to understand that, because we've been there too. So because of time, I won't be able to go through that in detail, but it is outlined in the book if you care to read about that. And then finally, I'd like to talk about caring for colleagues. And I'd just like to read another little passage from an article I wrote about the third arrow. And let's see if you resonate. Let's see if you resonate with this little story. So this is entitled The Third Arrow. And you might know the second arrow, which is a famous, very well-known, famous Buddhist parable about the second arrow. So I've modified the second arrow to the third arrow. So it is said that Buddha once asked a student, if a person is struck by an arrow, is it painful? And if the person is struck by a second arrow, is it even more painful? And then he went on to explain, in life, we cannot always control the first arrow. So the first incident, we can't always control the first incident. However, the second arrow is a metaphor for our reaction to the first. And this second arrow, according to Buddha, is optional. So sometimes this parable is interpreted as meaning that pain is inevitable, but suffering is optional. And so the second arrow is our tendency to hurt ourselves with our response to stress by overthinking our stresses. And in medicine, I would like to introduce you to the concept of a new third arrow. For when GPs experience significant work-related stresses, trauma, physical or mental illness, but are abandoned by their workplaces and their colleagues, are you okay is not enough in healthcare. As colleagues, as brothers and sisters, we need to care more about each other because the third arrow is deeply traumatizing and deeply painful for a clinician who has dedicated their life for caring for others, but in their time of vulnerability is abandoned by their colleagues because they're not pulling their weight, and they leave their practice. And this has also a really detrimental impact on other practice staff who see how a vulnerable colleague, a dedicated vulnerable colleague, is treated badly in a time of need, and they stand back and they say, and so this is going to happen to me in my time of need, and I'm leaving. And I believe that's at the root of why we're seeing people exiting the profession, because we've, in the last few years, particularly through the pandemic, we've actually had to face significant trauma, and we've turned to people and they've let us down. And so I realised that this is another thing that we're asking people to do, is to caring for colleagues. But could I put to you that are you okay is just not enough. And I won't go into that more deeply, but I'm sure that story resonates with you. So what I advocate for is that you connect with like-minded colleagues, because actually, from what I've seen in my leadership roles, doctors have more influence than they realise, but they need to unite. And often what happens is a disgruntled doctor will be a lone ranger and cause all sorts of problems, but actually does not generate any solutions. But if doctors work with like-minded colleagues and as a group come forward to advocate to leaders in government or in the health system and so on, then things change, because people realise that doctors are a really powerful group, and when they're advocating on patient care issues, they need to be listened to. And so the issues related to workforce shortages and all the challenges that I raised in my very first slide are relevant here, because if our medical organisations were united in their advocacy on these really key issues, then we would shift things, and that would make a huge difference to our working lives on the ground. And so don't give up on your influence. And when you look at that white sheet of paper that, that blank sheet of paper that I suggested you fill out about all the things you can't influence and accept the things you can't influence, I actually then, when you freed up a bit of time, you actually have more influence than you realize to change those things, but only if you work with your like-minded colleagues. And this is a part of leadership, and everyone in general practice is a leader, whether you identify with that or not, and you are a powerful group of people, and advocacy and stepping outside the consulting room is just so critical, not only for your workplace, but also for patient care. And that gets me to my final comment on purpose, because we can transcend our difficulties if we have an overarching purpose in what we do. We can face adversity, and it's like climbing the peak on the Milford track, isn't it? In a storm, and we get through if we have that. We have that purpose, and so I just finish on this note. The topic today, healthier general practice, healthier patients, and the book that Vihangi Abhiganawardana and Michael Kidd and I wrote, which I hope you find helpful.
Perfect. Thank you so much, Leanne. So we do have a couple of comments here, and I think, really, really important ones, that it's really hard to get that. And I know we've talked about the culture being the issue, but it's really hard to get that work-life balance at work when you have a fully booked clinic and a walk-in clinic, and there's no doctor's appointments available, and the nurses are trying to see the patients, and then, rescheduling conflicts and patients' expectations on us as clinicians, and how we're supposed to see them immediately. And yeah, it's a tricky one to navigate.
It's tricky, and I'm not going to pretend that I have all the answers, because I've been, I've worked in that environment for decades, and I know how chaotic it is, and I know how, the morning things might look pretty good, and then people are squeezed in, and there's an emergency, and then there's chaos. So I think that is part of the job, okay? But I think that the message here is, okay, we might not be able to control everything at work every day or every week, but we do have to carve out time to step back and really examine our lives about what is important to us, how we are going to endure adversity, how we are going to how we're going to deal emotionally with that chaos, and how we're going to use our precious time off work most effectively, so that we can recover to actually face that again the next day. And I don't pretend that any of that is easy at all, but I can tell you that through my experience and some of the little strategies that I've shared today, just sometimes simple things do make an enormous difference. And there are key priorities that we all need to identify and to focus through with that. And we need to accept that we can't be all things to all people, and that patients are angry because they're frightened. And, I have also seen this from the other side, as I'm sure a lot of the audience have, that we become patients too. And, our families develop serious illnesses, and, we're not immune from heart attacks and cancers and so on. And when you've experienced that as a patient, and you're waiting in a colleague's waiting room, and your treating doctor is burnt out, you recognize that as a patient, and you recognize suboptimal care, and that creates a lot of patient dissatisfaction and anger and complaints. And so by taking proactive steps to prevent the high levels of mental health problems that we're seeing in doctors is a really important issue. And that's why I'm prioritizing my time to talk to doctors about it. I don't believe I've got all the answers, but I really feel if we had another hour, and perhaps if we were face to face, and maybe you can do this in New Zealand, that you can convene a group to do that, then actually you do have the answers, but you just need to carve out some time to really be solution focused. Sometimes I find, Katie, that when I attend things like this, particularly face-to-face, it ends up being people offloading with, their problems, and they don't get around to talking about, well, what can we do about this? And it's not an individual, it's not often not an individual strategy. It's a practice discussion and a practice strategy, or it's working with the like-minded colleagues to actually advocate to our medical organisations and make them work on our behalf. Really make that, we pay membership fees. Let's make them work. And, if I can also say that if you're early in your career, please don't advocate, because you will destroy your career, But I think this is where senior doctors have a real responsibility to step out and speak out about these hard issues, and on behalf of younger doctors. And I really feel strongly about this, that often senior doctors don't do that. And there's this sort of pervasive attitude, oh, it was much harder in my day. We worked 120 hours a week. Well, actually, I think that's a falsehood now. I think coming out of the pandemic, it's much worse for practice staff these days, much worse, and with all the community expectations and so on. And I think we're doing, we're not doing 120 paid hours, but we might be doing 120 hours with all the extra admin, and by the time we're, so I think, Katie, despite all the challenges, I have to say that I have been so inspired by my patients, especially my young patients, who, when I see them come through the most enormous adversity, much more adversity than I have ever faced, and they come through with courage, and I know that it's authentic because I see them in their darkest moments. I mean, that gives me so much inspiration and optimism that in general practice, I think we've got such a privilege that we follow people through for a long time. And I'm sure all the people in the audience will know patients who you sort of meet initially and you think, oh, I think this is just an intractable problem. I don't think I can do anything. And then you follow them for years, and actually they recover from their drug addiction or their depression or their terrible bullying at work, and they actually get through and they become stronger people. And I think by having those incredibly important insights into life, it's a great lesson for us as clinicians into how we need to protect ourselves so that we can do the very best for patients like that. And really, in the end, when you come to the end of your career, what legacy would you like to leave? What was the ideal medical student? What were the ideals of the medical student in you, or the trainee nurse that made you choose this career? And what is the legacy that you want to leave? And I don't think it's a career of burnout and mental distress. It's not. We can be optimistic. We can find solutions. So.
Yeah, I think, as you say, it can be an incredibly rewarding career to have, and you can get a lot of joy from the work.
Absolutely, yeah. So again in the book, we've got lots of stories of joy and meaning and purpose. And actually, the other thing I wanted to mention about the book is that I was never a good writer as a student and in my early life, and when I worked in Indigenous health, which is so challenging in Australia, in far north remote Queensland, I just had to write about what I'd seen, because I just felt that there was a hardened attitude decades ago. And I mean, there still is, unfortunately. But I felt that I had to write about that experience. And it was the first article that was published, and it was published in an Australian Medical Association journal, and it got huge readership. And people still tell me, it's actually in the book, in Every Doctor Now at the end, and people tell me that had such a great impact on them and helped them make a decision to work in Indigenous health as well. And when I think about that, it actually challenged me to learn how to write. And so I write I've written for decades as therapy, really, to work through some of these really intractable issues. And then I get feedback from like-minded colleagues, and that challenges me to write more. And my message would be to the audience, think about taking up writing. It's really empowering, and maybe someday you'll publish, and you can make a huge leadership difference by writing about your experiences. And I realize that there are important confidentiality considerations there, but you can de-identify and tell some really powerful stories. So
someone just made a comment about the health improvement practitioners that were established in GP practices for around about 3 years now, and they can provide really useful tips and tricks for wellness for colleagues.
Oh, fantastic.
Breathing techniques, somatic exercises for overwhelm, and much more. So I thought that would be a really nice thing just to...
Oh, that's so wonderful. You need to give me information about that, because we don't have that in Australia.
And finally, just you mentioned before about senior clinicians standing up for the junior clinicians, and there is a comment here. As a junior doctor RMO currently doing their GPEP, they find it quite challenging to balance the learning from seniors versus attempting to raise potential concerns about workplace culture in a respectful but appreciated manner. And sometimes the fresh eyes or point of view can seem like they would be a positive influence, but it can be quite intimidating raising these ideas as a team. So any very quick advice
Look, that
on how to manage those situations?
I absolutely understand that challenge. And so look, I don't have an easy answer for it, but I know that the articles that I've written in the MJA Insight, and even in the book, Every Doctor, that can be a way of introducing these challenges to people about contemporary HR management and HR law, because often it relates to actually the basic right to have a safe workplace and a safe culture, and a civil culture. And so I find that providing people with some reading material or on these issues is helpful. So using my articles on these topics as discussion points, for example, can help open up quite a few issues. But again, I would also encourage early career doctors to talk to each other, because they're shared challenges. It's not only you, but facing this. And by sharing, if there are other early career doctors in the practice, for example, really having a chat to work out, is this a common issue? Is this a systemic issue that we need to raise with our supervisor, who might be the more appropriate person to actually raise it with the practice owner or the more senior GPs. So just for an example, there's been a big issue in Australia. It's actually not in general practice, although it probably is to some degree, but in public hospitals, there's been a big issue around wage theft. So doctors working during the pandemic and working unpaid extra shifts and really unsafe hours, but not getting paid for that. And then senior doctors, because they need to seek permission from the senior doctors to put in the extra hours. So they're asked to work the extra shift, but they're not allowed to put in the extra hours. I mean, it's just unthinkable during the pandemic, when a lot of these are frontline doctors working with the trauma of people dying of COVID, and are just unthinkable. So I spoke to some young doctors about this, and they said, we just don't have any voice in this, because these doctors are they're responsible for our appointments the following year. We've got poor tenure, we don't have contracts for more than a year, and we just can't raise this as an issue. And so I just was incensed by this. I just couldn't understand how this could happen. So I wrote a very powerful article on wage theft and the responsibility of senior doctors and so on, and it got a huge readership. And I know that people use that article to circulate you know, around to public hospitals. It just got, you know, tens of thousands of reads. And in fact, there was a recent court case where the court ruled against the public hospitals on the wage theft issue. And so the junior doctors won the case. And so now they're going to be back paid for all of that pay. Now, I don't pretend that it was my article that did that. I'm sure that it's not alone, but there were a group of young doctors who got together and joined a class action. And with their, you know, the sheer sort of, you know, scale of the people who joined that class action, then they took, you know, they went to court and they won their case. And so, you know, that's just a small example of a sort of a really, I mean, just an obvious human rights abuse, you know, that was just intractable until there was senior advocacy on it. Yeah. So again, completely
what you can do with like-minded colleagues.
Exactly. Completely understand how you could feel so impotent as an early career doctor when other people are deciding for you, you know, your future employment and your future career prospects, and how fraught that is, how really fraught that is in an unsafe workplace. Yeah. But even, I think you're also the person who made that statement and was talking about not even the unsafe workplace, but just general quality improvements. And I'm just such a great believer in continuous quality improvement. So, you know, if there's a suggestion and feedback, you know, I just welcome that with open arms. I just think that fresh approach is so important. So I don't think every practice owner is, you know, pushing back on that. I think there are a lot of doctors who recognise the great contribution that early career doctors make.
And that is everything from us tonight. So again, thank you so much, Leanne, for being with us and taking your time and carving it out for us.
Thank you, everybody. I really enjoyed it. Thank you. Take care.